At the outset, let me thank the organizer of this meeting to giving me this opportunity. And since one speaker is missing, so I can ask for an extra minute. So acute variceal bleeding is the most important complications of portal hypertension, which occurs in more than 2/3 of patients with liver cirrhosis. And most of the time it is controlled by these measures and doing endoscopy within 12 hours of admission, restrictive transfusion, antibiotic prophylaxis, and vasoactive drugs. But sometimes in around 10-20% of patients, there is a failure of control of bleeding, which is defined as onset of any of these things within 48 hours, like a fresh bleeding episode after a successful endotherapy, patient developing shock or a fall in hemoglobin or hematocrit within 48 hours, or the patient dies within 24 hours. Sometimes once the bleeding is controlled, there could be rebleeding, and the rebleeding, it could be early rebleeding after 48 hours up to 5 days, or a late rebleeding up to 5 days, which occurs because of failure of secondary prophylaxis. And this rebleeding is significant if the person requires hospitalization, requires blood transfusion, there is a fall in hemoglobin, or the patient dies within 6 weeks. So a refractory variceal bleeding is defined as a failure of control of bleeding or a failure of secondary prophylaxis, which occurs in 10-20% of patients who comes with acute variceal bleeding. And the treatment failure can be defined anybody who failed to be controlled of bleeding within 5 days of admission. What are the predictors of refractory bleeding? It again depends upon the underlying liver disease, the all CTP and MELD, presence of portal vein thrombosis, or presence of hepatocellular carcinoma. And again, the high HPPG also predict the failure of bleeding. So with this background, I will talk on the topics: difficult to control variceal bleed. I'll just roughly divide it into 3 components: a refractory esophageal bleed, a refractory gastrofungal bleed, and a word about the post-EVL ulcer bleed. Whenever a person comes to you with acute variceal bleed within 24-48 hours or more than that, whether it is a failure or a rebleeding, the logical next step is to do a re-endoscopy. A re-endoscopy is feasible. If it is not feasible, or if the second endoscopic episode is also fails, then there are then we have to look for something else. The options are balloon tamponade, the local compressive therapies, you shunt the portal pressure, and there are other ways and means of treating the gastric varices. We'll take one by one. Balloon tamponade has been there since long. There are 3 types of tubes. We have the Sengstaken triple lumen, the quadruple lumen Minnesota, and the tube specifically used for gastric varices is Lincoln. Since the first publication by Sengstaken and Blackmore in 1950, these has been the common method of bridging the therapy, the common method of treating the refractory variceal bleed all decades. And this publication, a largest series, 151 consecutive patients. They included both patients with failed esophageal variceal bleed or gastric variceal bleed. They used SB tube or the Lincoln tube. The primary target of outcome studied was primary hemostasis or permanent hemostasis. What are the complications? So around 90% of patients, the bleeding can be controlled, the primary hemostasis. But the death was significant number of 1/3 of them die. The number of complications remains the chest pain, aspiration pneumonia, lung necrosis, and the transient airway occlusion. So the primary hemostasis is efficacious. Adverse event occurs in around 20% of patients, but it cannot be kept for more than 24 hours, and around 50% of patients rebleeds. A very recent publication on the efficacy of Sengstaken Blackmore tube in the uncontrolled variceal bleed. There again the treatment targets were the bleeding control rate, mortality rate, and what are the predictors of hemostasis. Again, out of 512 patients, they could include only 66. 50% the bleed can be controlled. In 16, the bleed cannot be controlled, and most of them died. Out of those who had initial bleeding control, 11 patients they rebleed, and the many people died following the rebleeding. So the variables which were predictor of mortality in patients who were used with second tube were non-intubated patients and advanced liver disease. So SB tube might be a beneficial option for a temporary salvage, but it has got fatal complications. So what is the next choice? Self-expanding metal stents, the pathophysiology is same. It directly compresses the varices to stop the bleeding. The first publication occurred, this is the landmark publication in 2012, acute management of refractory variceal bleeding in 12 patients with cirrhosis used with self-expanding metal stents. And out of the 3 metal stents available, the commonly used one, the Dennis Ally stent. It can be placed maximum up to 2 weeks, and there are complications also. So what does the current literature says about this? This is a meta-analysis published in 2016, 12 studies, 155 patients. The clinical success, 96%, technical success, 97%. Adverse events, 1/3, 36%. The common events were stent migration and rebleeding following the removal of the stent. The 30-day survival is 70%. The another meta-analysis published this year, 24, again 12 studies included. The efficacy is around 90%. Again, immediate bleeding control is around 91%, rebleeding in 17, stent migration in 18, and all-cause mortality remains same around 40%. How does it compares with the balloon tamponade? So the comparative randomized control trial between balloon tamponade and the esophageal stent. This is the only randomized control trial available in the literature, and they could include only 28 patients, 15 in balloon and 13 in SEMS group. The success with esophageal stent was 66% compared to 25% in the balloon group. Transfusion requirement adverse events are also lesser with esophageal stenting group, but the 6-week survival, and there is no significant difference. So overall, the SEMS nowadays is preferred over the balloon tamponade. And these are the differences between, although it is costlier, but it is an efficacious therapy. A word about the hemostatic powders. There are 3 types of hemostatic powders available. International Hemospray Registry could include only 12 patients for variceal bleed use of hemospray, and there was 75% immediate hemosis. There's not much literature available on this subject, and it can be used only as a bridging therapy. Coming to the shunting procedures, TIPS is the commonly used shunting procedure. And TIPS could be of 3 types. A salvage TIPS means a TIPS done in a refractory acute variceal bleed when the endoscopy fails. It could be a preemptive TIPS, means once the person is stabilized by your bridging therapy and you perform the TIPS within 72 hours. Or it could be a TIPS used as a secondary prophylaxis after the control of acute variceal bleed after 5 days. The literature, what is the literature on salvage TIPS? So this is a salvage TIPS, predictors of bleeding and mortality. 144 refractory patients. The aim was to know the predictive factors and 6 weeks and 1 year mortality. Mortality rate is quite high, 6 weeks, 12 weeks, around 42 patients. Rebleeding is 16% at 6 weeks. Male density are the predictors of long-term mortality. Again, the pre-TIPS ICU state associated with the TIPS failure and the high mortality. And emergency TIP is futile in patients with late child C. The other predictors studied about the 2 more added. One is serum lactate level and the MELD score. So MELD more than 30, serum lactate more than 12 predicts more than 90% mortality. So salvage TIPS is not effective in these group of people. How does TIPS compare with the self-expanding metal stent, the salvage TIPS with the SEMS? 547 patients, 11 studies. Primary goal was to analyze and compare all-cause mortality, immediate bleeding control, and the rebleeding rates. You can see the mortality and rebleeding was less with the TIPS, and rebleeding and both were less with the TIPS. But if you can compare the immediate bleeding control, comparable, technical success comparable, adverse events almost comparable. So SEMS in refractory EV bleed demonstrate a acceptable immediate bleeding control with good technical success. What about the early TIPS? This is the landmark article in NEJM 2010, use of early TIPS in patients with cirrhosis. The 63 patients were randomized to receive either the standard of care, the vasoactive plus band ligation, and the early TIPS. Clearly, it shows the survival benefit with the early TIPS compared to the standard of care therapy. Again, the freedom from uncontrolled bleeding or rebleeding was better with early TIPS compared to the standard of care therapy. So early TIP is a better option. What are the factors which will influence the early TIPs in patients? So this group measured the people into two groups. Those with the high SVPG are called as high risk group, more than 20 SVPG, and the less than 20 SVPG was the low risk group. And people with high SVPG were divided into again two groups, with those who underwent TIPs within 24 hours and those who didn't receive the TIPs. So compared to the high risk, high SVPG, no TIPs. And compared with the low risk patients, they had high treatment failure, high transfusion requirement, need for intensive care, and the worst actual probability of survival. So anybody with high SVPG should be subjected for TIPs to prevent these complications. And the early TIPs placement in these group of patients reduce the treatment failure and the in-hospital and the one-year mortality significantly. But one thing, early TIPs is not panacea. It may prevent rebleeding, but it will not it will not improve the underlying liver status. So if these people are candidates for liver transplantation, they should be referred for liver transplantation. So to summarize, preemptive TIPs or early TIPs is the key, especially hemodynamically stable patient within 72 hours, child C or male more than 19. Secondary TIPs can be used in patients who have an SVPG of more than 20. A single study comparing TIPs versus surgical shunting, again the Marshall-Orloff group, and emergency TIPs versus emergency portocable shunts. Again, a surgical group publication in surgery, and they talked all good about the surgical shunting compared to the TIPs. But we all know in practice, it's very difficult to subject these group of patients into a definitive surgery like shunt or others. So to summarize, the difficult to control esophageal variceal bleed, the options is vasoactive therapy, continue beta blocker if the patient improves. If they rebleeds, you go for early TIPs. If there is uncontrolled bleeding while the person is presenting to you, you go for a bridge therapy. SCMS is preferred over the balloon tamponade. The salvage TIPs early TIPs is better than the salvage TIPs. Gastrofungal varices are a different cup of tea because of their location, and their bleeding is unrelated with the portal pressure. So they need to be tackled differently. Balloon occluded retrograde transvenous obliteration is one of the method of stopping the bleed from the gastric varices, which can be done with the help of BRTO, with the help of a sclerosant or a coil or a vascular plug. And this is the recent meta-analysis in BRTO in patients with refractory gastric variceal bleed. More than 1,000 patients from 28 studies. Outcome studied was immediate technical success, clinical success, and complications. And you can see the technical success, clinical success are quite high, more than 95%, and the complication rates are quite low. And these are the major complications. How it compares BRTO with TIPS in gastric variceal bleeding. So it's a retrospective study, 95% in BRTO group and TIPS 47%. Is very important. BRTO for gastric varices, the cumulative incidence of rebleeding is quite less compared to the TIPS. So a cumulative rebleeding with BRTO is less compared with the TIPS. And the independent predictors of rebleeding in these group of patients is if they have undergone TIPS, it's a predictor of rebleeding, a concomitant SCC and a baseline poor child book score. So the difference between TIPS and BRTO is reserved for patients with gastric variceal bleed. And the TIPS is usually preferred for patients who have esophageal varices or under indications of TIPS. And BRTO is only for, they have to have a patent renal shunt to perform the BRTO. Lastly, a word about the EUS guided. You know, the EUS has emerged as a promising management options, either a endotherapy using a direct freehand technique of injecting glue, or a EUS guided glue or glue plus coil or a coil alone. So this is a very recent meta-analysis comparing the monotherapy versus combination therapy. Again, 11 studies, more than 500 patients. So a group with glue alone, glue plus coil, and the coil alone. Technical success almost same in all three. But the clinical success is much better in glue plus coil compared to the coil alone. And whereas these all three events, the adverse events, re-intervention rates, and the rebleeding rates are much better with the group with glue plus coil. So the standard of care should be the coil and glue is preferred over either one of them. This is a classical landmark article from Ben Moller, largest US experience, gastric varix, gastropundal varix, GOV2 or IGV1, glue plus coil. I will take 1 extra minute. And it's found to be highly effective. The combination therapy is highly effective. One of the Indian study where they have studied the people who rebled after glue. So again, two categories. After rebleeding following glue, either glue was re-injected or a EUS guided coiling was added to it. So in a group with where the glue was re-injected, 50% rebled, whereas in glue plus coil only 6% rebled. So it's better to go for a combination therapy. So a summary of the management of gastropundal varices. In a controlled patient where the bleeding is controlled, you go by the standard endotherapeutic management. The standard of care remains same. In uncontrolled bleeding, if you are planning for an endovascular treatment, a BR2 is not possible because of absence of linorenal sand, you go for TIPS. If BR TIPS is contraindicated, again, you can go for BRTO. In a patient where both TIPS and BRTO is possible, then they look for the underlying liver function, presence of large varices, presence of ascites or PVT, which will favor the TIPS over the BRTO, whereas previous encephalopathy, poor liver function, will favor the BRTO over the TIPS. A word about the post-EVL ulcer bleeding. It's very common, occurs in around 2 to 3% of patients post-EVL, and mortality is very high. And they have been graded as per this classification proposed by the Jambal group, A, B, C, and it's just akin to the ulcer bleed. And this is again the same classification. And I could find 1 or 2 articles. The salvage treatment is with SEMS and 82% control rate with SEMS, and the survival is quite good. So a summary of approach to a patient with post-EVL ulcer bleed, you just classify them. If there are higher grades, they can be subjected for TIPS or otherwise indicated liver transplantation. With lower grade, you can try the endoscopic therapy. So ladies and gentlemen, to summarize, refractory variceal bleed is either due to failure of control of bleed or failure of secondary prophylaxis. Bridging therapies like self-expanding metal stent is preferred over the balloon tamponade in these group of patients. Preemptive or early TIPS is preferred over the salvage TIPS. And the EUS-guided glue plus coil and BRT are options for refractory gastric variceal bleed. And the severity of liver dysfunction and classification will guide the post-EVL ulcer bleeding. Thank you very much.
Okay, so I think one speaker is missing. Okay, so it's my privilege to call on stage Dr. Dinesh Jyotimani, and he's from Dr. Ela Medical Institute. And welcome to the dais.
Thank you, sir.
And you can begin. So we'll have discussion at the end for both.
Good afternoon, chairpersons and everyone here. So this is an important talk for people involved in a liver transplantation, because patients with liver cirrhosis are at a very high risk of sepsis and septic related complications. So these patients are obviously been worked up for liver transplantation. When they develop sepsis, everything goes haywire and the patient decompensates and then end up in the ICU with multiple organ supports and organ failure due to organ failure. So the question comes, when to decide on liver transplantation in a patient who developed a recent infection. Let me go back to the basics and one step backward. It's always important to learn the basics properly. We always use the word infection and sepsis, in otherwise but they're not the same. They should never be confused. Infection is due to an infective agent, obviously, but with localized symptoms. Whereas sepsis is a presence of systemic symptoms like fever and tachycardia and organ dysfunction. So this is very important to understand. Sepsis is caused by infection, okay? And if they have only localized symptoms, they are called infection alone. This is a very basic understanding. And of course, if they have hemodynamic instability, they are called septic shock. How do you manage these patients? For infection, you give antibiotics. Of course, look at the source control. Whereas if they have sepsis, you need to manage the hemodynamic status, you need to manage the systemic symptoms, like you need to give IV fluids, you may have to start inotropic support. So this is very important to understand, particularly in the context of cirrhosis. Now, just look at this slide. We have a very stable decompensated cirrhotic patient. That means those who had one episode of variceal bleed or one episode of encephalopathy, who's been waiting on the list for liver transplantation. And they've been hit by an infection or a septic complication. The liver worsens, they become very unstable. They develop more ascites, encephalopathy. They may be admitted in the ICU directly or be admitted in the ward, or this may trigger variceal bleed. This is one scenario. The other scenario is a stable decompensated cirrhosis. When hit by sepsis, they may progress to acute on chronic liver failure. So you can have various combinations. If an unstable decompensated cirrhosis develops sepsis, the liver may worsen and they may develop acute on chronic liver failure. At the same time, if the patient with ACLF, when they develop sepsis or even infection, the grades of ACLF may worsen and they end up in multi-organ failure. So this is where it's important to differentiate between the two. So if a stable decompensated cirrhotic patient develop infection, which is very mild usually, they may develop unstable decompensated cirrhosis, but they may go back to their initial baseline levels once you treat the infection. Whereas if you have a stable decompensated cirrhosis, if they develop sepsis or septic shock, then things may be very vulnerable, and these patients have high morbidity and mortality. Of course, patients with acute on chronic liver failure may develop septic shock because they don't have enough reserve and they deteriorate very rapidly. So there are multiple studies because we know cirrhosis is a risk factor for infection and sepsis. There are multiple studies to look at the sources of infection in these patients. They are conducted worldwide and multiple single center studies. So most of them, if you look at it, is spontaneous bacterial peritonitis, urinary tract infection, and pneumonia. This can occur in various, depending on the literature you look at, depending on the center you look at, it may vary. The pneumonia may be on the top, SBP may be in the second. So when you have a cirrhotic with bacterial infection, your mortality will be very high. It's 1/3 of them die. And particularly if you have a high ML, that means if your liver disease is bad, on top of that, if you develop infection, you're not going to survive frequently. Now, this is a worldwide epidemiology study because there are multiple single center studies. This is a worldwide study looking at over 1,300 patients across the globe, across all the continents. So they found that urinary tract infections most common, followed by bacterial peritonitis, pneumonia, and other skin and soft tissue infection, that order. And if you look at the bacterial the format, it is E. coli is more common, followed by Klebsiella, and in the West particularly you see Staphylococcus aureus. What we see in our population is generally multi-drug resistant bacteria, which worldwide it's around 34%, but slightly higher in our country actually, because of antibiotic usage. Now, if you develop infection before transplantation, there's a high risk of post-transplant infection. So there is nearly 4x fourfold increase in post-transplant infection infective complications if you have infection in the last 3 months prior to liver transplantation. This we all probably know. But what we need to know is if you have pre-transplant infection, there is high mortality in the post-transplant period, particularly in the first 3 months. There's 2.5 times you're likely to die in the post-transplant period if you have infection in the pre-transplant phase. Now, this is also true and much higher if you have MDR bugs. So if you have MDR bacteria, you are more prone for longer ICU stay, longer hospital stay, and much, much higher mortality. But these are slightly on the older studies. But there are new studies showing slightly different results. So this is an Italian study published very recently looking at the impact of bacterial infections prior to liver transplantation and looking at the post-transplant outcome. So it's a case control study on 466 patients who had bacterial or fungal infections within 3 months before the liver transplantation. And those who did not have infections served as a control group. As we know that patients who had pre-transplant infection, there is high chance of new infection in the post-transplant period. There is more bacterial. Those who had bacterial infection had bacterial infection in the post-transplant. So these all we know already. And there is increased ICU stay and increased hospitalization in the post-transplant phase. But what the authors were surprised were there was no impact of pre-transplant infection or no influence on the overall survival. This is very new for us. This is a very new information. So if you have pre-transplant infection, your survival is not really affected, either 1 year or even 5 years. So if you look at the 1 year survival in those who had pre-transplant sepsis, around 88%. In the control population, 89%, and very similar in the in the 5 year survival rate. So this is a very welcoming news for people who are dealing with these sort of patients. But the important question is, when do you transplant them? In the same study, they looked at slightly different perspective. So they compared the patient who were transplanted within 7 days of infection to patients who were transplanted beyond 7 days of infection. To the surprise, once again, there was no statistical significance in the overall 1 year survival. There is no statistical significance in the 5 year survival. And it doesn't matter whether you carry wild bacteria or multi-drug resistant bacteria. So if you treat them properly, definitely you're going to have a better survival. So you can still transplant this patient within 7 days of their septic complication. So this brings a concept of what we call as controlled sepsis environment. What is controlled sepsis is, so previously when we are in medical school, we always give antibiotic for 7 days, 14 days, make sure there is radiological recovery, make sure the patient is back on track. So this controlled sepsis environment is where the patient receives appropriate antibiotics for a period of very short duration, maybe 48 to 72 hours. There is improvement in systemic inflammatory response, and definitely there is no hemodynamic deterioration. So for example, if a patient has pneumonia, you give antibiotic and they don't deteriorate, the oxygenation doesn't worsen, then definitely you should consider them for early liver transplantation in patients who need transplantation. So let's talk about the common sources. So urine infection and the timing of liver transplantation. Many times we come across this scenario. There is urine shows bacteria, the patient themselves are asymptomatic. They are not contraindications for transplantation. Anyway, you're going to give antibiotics at the time of transplantation, you can go ahead with that. Patients who develop UTI with negative blood culture, you can consider, you should go ahead with the liver transplantation, giving higher antibiotics. Whereas if UTI causing sepsis like pyelonephritis, if there's a stone in the kidneys that's causing problems, you need to give antibiotics for 5 to 7 days and do the source control. Maybe they need a stenting of to relieve the hydronephrosis. And if the hemodynamic status doesn't worsen and that there should be some negative blood culture in 48 hours. If this is the scenario, definitely you can consider them for early liver transplantation, because once the liver deteriorates, once they go into ACLF, it's very difficult for them to come back, particularly if they are in stage 2 ACLF. And what about pneumonia? In patients who are planned for liver transplantation, you need to give antibiotics for 5 to 7 days, and there should be improvement in your oxygenation. This is very relevant in patients who are in the intensive care unit, and those who are ventilated, they should have a very stable ventilatory support. Their oxygenation should not increase. Their FiO2 saturation should not go up. And the important point is, we all know that the radiological recovery will take around 4 to 6 weeks. So there's no point in doing repeated scans, but as long as they are stable. But we do scans to make sure they're not worsening. That's very important. That's the role of doing a CT chest and or a chest X-ray. So if they are very stable on antibiotics, oxygenation is on the lower side, on the improving trend, definitely these patients should be considered for transplantation. On the other hand, if the FiO2 is increasing on a day-to-day basis, definitely transplant should be withheld in these patients. The more common, we are talking about spontaneous bacterial peritonitis. You should give treatment for 5 days if you detected early, and then you should do a repeat tap, make sure there is a decrease in the neutrophil count within 48 hours of antibiotics. So if you can come across this situation, once again, you can transplant them. You don't have to wait for 14 days, like that, as we used to think in the past. So things have changed. This is more important. What about fungus? Very often we come across patients have candida in the urine, and that's absolutely not a contraindication for liver transplantation. All you need to do is change the urinary catheter. But whereas if they have fungemia, if they have mold, and that's a very different scenario. So if you have a mold, you need to give good going antifungal therapy for at least 14 days, see some improvement in their radiological characteristics. And at the same time, if they have candida in the blood, that should be treated with appropriate antifungal, probably echinocandins, as we discussed earlier, and then consider for transplantation. So therefore, patients who require liver transplantation, if they develop sepsis, you should manage them aggressively. I'm not talking about patients who come to ICU with ACLF grade 3, severe sepsis, not candidate for transplantation. Because if they are not candidate for transplantation, I don't think you should follow this approach, because they have a very, very high mortality. So if you have patients for liver transplantation coming with severe sepsis, you need to start them on antibiotics, empirical antibiotics, send cultures, screen them aggressively. Once you know what bug you're treating, change your antibiotics appropriately, and if they get better, de-escalate them, and then consider for early transplantation. Whereas if they're not getting better, you need to know whether your diagnosis is correct, whether your antibiotics is correct. So you need to consult your infectious disease team, maybe consider adding antifungal drugs. So these things are very, very important, and it's a multidisciplinary team approach, particularly in this scenario here. Always we talk about scores in liver disease. This is a very new score, not recently, probably 8 years ago introduced. It's called based on sepsis-III consensus. So I always look at SOFA score and get confused, because there are a lot of parameters. It talks about every organ in the body, actually. So, but this is very easy. That's been comparable to your conventional SOFA score. If the respiratory rate is more than 22, they have altered sensorium. If the systolic blood pressure, not on beta blocker, if it's less in a septic patient, consider shifting them to ICU and manage them aggressively before considering for liver transplantation. So this is my last slide. So timing of liver transplantation after an episode of sepsis is not very clearly established, but based on experience and based on, there cannot be a randomized study on all this. So pre-transplant sepsis is a risk factor for post-transplant infection. There is increasing evidence to show that sepsis has no or less, probably I would say, impact on the post-transplant survival. Aggressive management is recommended in patients who are candidates for liver transplantation, and surgery should be offered once the sepsis is controlled. Thank you very much. Thank you.
Thank you for the excellent presentation. The topic is open for discussion.
One question for Dadhich. I see surgeon missing from the list because most of the times the anecellular stent is not available in the hospital or in the town, and every center is not coped to do BRTO and TIPS procedure. So we recently had an experience, a massive variceal bleed not responding to EVL. We had to push the patient to surgery after placing a Sankstein tube. Where do you see a role of surgeon in this?
Actually, when you look for the predictors of refractory bleed, it's the underlying liver function which predominates. Like if a person who's having a child C or a late child C or a high SPPG are more likely to have a refractory variceal bleed, because a bleed which is not controlled by the usual EVL and other things, they usually have a severe underlying liver disease. So subjecting that group of patient to a surgery is again difficult.
High risk, but we don't have any
Yes, sir.
option. I told you our experience.
Yes.
We had to push him for surgery, and he survived
Yeah,
devasculization.
if they can undergo surgery, then probably it's a good option.
In this regards, you can take the mic. What we often do not discuss in these meetings is the role of coagulation, because we keep talking of balanced coagulation. Now your patient in this scenario has a platelet of 20,000, 30,000. INR is 3, 4. What do? He has rebled. Would you even take this into consideration? What's the hepatology status?
For repeat endotherapy or a
Whatever.
radiologic procedure?
You have done a procedure, patient has
You have to
bled.
correct it, because that's where comes the importance of the underlying treatment of the underlying liver disease. If the underlying liver disease is advanced or it's a ACLF, then he's more likely to have these kind of complications which
Yes,
we are
so
talking
would you
about.
now, in today's era, correct the platelet, correct the
Not by the
INR?
absolute number, but by the viscoelastic assay, and then you accordingly give the factors and then.
Okay, so please.
So patients with ACLF, when they present with bleed,
Yes.
they have very, very high risk of rebleeding.
Yes.
The portal pressure is so high.
Yes.
Would you change your practice in these patients going for early SEMS, or if they have a rebleed?
The first approach is always a stable, a person should be the endotherapy, doing EVL or glue or coil, whatever, depending upon the site of bleed. If they rebleed, then it again depends upon the underlying liver status, whether they are the candidate for liver transplantation or they're going into that futile category. Then once they are stable, then you can go for a shunting procedure. The TIPS can be done even a bridge to transplantation also.
TIPS in our setup is very difficult generally, because if they decompose, the TIPS data mainly comes from the West,
Yes.
because if
For
patients
cirrhotics,
decompensate,
yeah.
you can get the next cadaver organ to the patient. Whereas in our scenario, that is not very easy to do that. So therefore, if you look at the whole literature, TIPS is very less performed in our country. That's one of the main reasons. So that's my question. So if ACLF patients rebleed, I would say it's better to go for early metals, self-expanding metal stent, rather than rebanding and all those.
Yeah, that's why I told
rather
you
than
endotherapy is the first preference of doing the procedure. Yes.
I agree with you, Dr. Dinesh. Actually, when you see these studies of preemptive TIPS, they are not actually reducing the rebleeding in that way. They are actually preventing further decompensation and hence improving the mortality. So one has to take that into mind, that once whether it is your short-term goal or you are looking at a long-term goal here. And preemptive TIPS, actually the survival benefit comes in selected group of patients, the CTP and active bleed and up to 13 and futility concept, because these are patients who will be helped by TIPS. Not only, obviously, they will prevent bleed, but mainly in preventing further
otherwise also it is,
decompensation and
yes.
hence improving survival indirectly. So,
Yeah. So if TIPS is otherwise also indicated, then you should prefer for TIPS. Then otherwise stay for endotherapy. Do go for freezing and then repeat the endotherapy.
we can take one or two questions from the house, but in the meantime, a question to Dr. Dinesh. You mentioned that with SPP, you are okay to take up for transplant within 5 days of antibiotics. Is that, did I understand correct?
Yeah, that's right. So this is in an unstable patient. That's what I'm saying. If a patient has spontaneous bacterial peritonitis, particularly if they are ACLF, and if the liver function is not going to improve, and if they are stable, if they are not, even if they develop acute kidney injury, they are not candidates, they are candidates for liver transplantation. I mean to say they are not contraindication for transplantation. Particularly what we have an advantage is the living donor transplantation, where you can actually plan the transplantation during the window time rather than waiting for the entire sepsis to completely recover, yes.
And what's your take on gut colonization? Because many of the time you resolve the infection, not talking of the infection, and the bowel remains colonized with MDRs. So does it influence your take on subsequent?
Yeah, I mean, there are conflicting evidence on your gut bacteria, particularly MDR colonization in the gut. But the main problem is the liver. So once you change the liver-related sepsis and all those things it will come down. So that's a lot.
There's a question from the house.
Sir, good afternoon. My question is to Dr. Dinesh, sir. Sir, excellent talk. Just wanted to know, like if there's a patient and in a LDLT scenario, usually we do prior testing prior to the transplant. But unfortunately, 2-3 days prior to the transplant, the donor comes positive for COVID-19, and the recipient is not having any symptoms. Should we wait for the incubation? Because they are from the same household and there is always an exposure. So should we wait for the incubation period to go off for the transplant to go ahead, or how long should we wait?
Question is, what if the donor is become the COVID positive, okay, and the recipient isn't? This is not an uncommon scenario. It's even recently we had. So first thing is, obviously, if the donor is COVID positive, they can't go for donation for at least for a week. So that gives an incubation period for the recipient to look at whether they turn COVID positive or not. So anyway, you're going to withhold the transplantation because the donor is not suitable, actually.
But how long should we wait for the incubation period?
This is regarding your comment about coagulation correction and refractory variceal bleeding. I know we're on the other opposite ends of the house on this. There's a big RCT from ILBS which is looking at tranexamic acid for prophylaxis of preventing secondary variceal bleed, and they looked at the viscoelastic test and the fibrinolytic test, and there was absolutely nothing on either to show fibrinolysis. However, giving tranexamic acid for 5 days as an infusion at a dose which we know might cause microthrombosis elsewhere was found to have survival benefit. So what coagulation test can be used for actually correcting coagulation abnormalities when this very large RCT has demonstrated survival benefit for an antifibrinolytic agent when no fibrinolysis has been demonstrated by any of the yardsticks we currently have? That's the first. Second thing is, if we are going to be correcting coagulation, we need to be looking at the portal pressure reduction first. As you pointed out, survival benefit will come from portal pressure reduction, and by means of reduction of HVPG, further decompensation is prevented and survival is prevented. It has very little to do with bleed. So whether we correct the coagulation or we don't correct it, unless we achieve that portal pressure reduction, whether by vasoactive drugs or by TIPS, it's not going to help. And in high MELD situations where TIPS is a contraindication, maybe Danicella may buy some time. If there's sepsis, then we correct coagulation, hyperfibrinolysis, and buy some time. But again, to correct coagulation, I'd like to point out to the house, it is generally dysfibrinogenemia, which is the problem. So giving fibrinogen concentrate in cryo might help more than giving FFP. That would be the very last thing to correct.
So that's yes, correcting coagulation. That's exactly what I meant. So it didn't necessarily means FFP. So correcting dysfibrinogemia, platelets to me is important because and as we say, the viscoelastic tests are not available everywhere. These are still in niche situations. So what we have in hand is platelet, INR, fibrinogen level, and that's what we have to make do. But the proof, and I keep arguing in this way, is that the patient is bleeding. I do not need any other proof. Obviously, I know the portal pressure is high. And then if I have deranged coagulation in a patient who is actively bleeding, I don't think I would want to ignore this fact. Because the proof is in the pudding. The patient is bleeding. And now I don't think viscoelastic tests tell me that his coagulation is stable.
Agreed with you, sir. Now I give you the same VET test result in a non-bleeding patient. If that same VET test result is being attributed to being the cause of bleeding in a bleeding patient, why do we exclude the non-bleeding issue in a patient with the exactly same VET?
Because
so these are incomplete measures of coagulation.
Because now you are comparing my clinical acumen or my clinical observation with a lab test. And if there is a discordance, that is my basic
Then
premise.
based on the clinical
between
situation.
my clinical suspicion and a lab test which doesn't agree with my clinical findings, then I'll believe my clinical findings. At the end of the day, the patient is bleeding in front of me. The test doesn't tell me that, look, he's stable.
And this is how the tranexamic acid data has come from ILBS.
I think in my unit, my practical approach is to a person who has refractory bleeding, look for two things. The MEL.CTP, if it is very high, then the person is anyway is not going to survive for long. If that is normal, like his early child C or B, then the culprit is HBPG. You have to reduce the pressure some way or other.
But Bavino
No, these are simultaneous. Obviously, we are reducing the HVPG, we are giving the vasoactive drugs and all. Those we are not denying. So they go on.
So, and
now
the
he's-
tips can be performed despite the abnormal
And now he's
coagulation.
refractory to your measures. That was the topic.
But
These are not working.
Everything is intravascular, so tips is not a contraindication for doing
But
this.
Bavino consensus also says that FFP transfusions won't improve the survival in bleeding patients.
Fair enough. So FFP, yes, because the volume expand, but correcting dysfibrinogemia, giving respect to the absolute fibrinogen level, understanding that in alcoholics you will have dysfibrinogemia, infections cause, and there are endogenous anticoagulants. And at least so many of these factors, platelet functions go down. At least I think these should not be disregarded. And well,
We should aim at HVPG reduction.
so that's one thing. And so there is an implosion theory and there is an explosion theory. So everything is not portal hypertension. That's just my take. You have to have a primary clot formation at the site of the variceal rent, regardless of the portal pressure. Even if you cut, a clot has to form.
You will agree that it's been a great discussion, and both the speakers, the presentations were well-paced, organized, and the messages were clear. Now, we have with us Dr. Roy Mukra, who's one of the authors in the paper that Dr. Sunil quoted. So I'd like to close with some comments from him about the glue injection.
No, it has been well proved that glue and coil combination is a good option for the refractory bleed. We have used only it for refractory bleeds. And now the thrombin has also come into the place, so thrombin is also has been used. So probably we'll have more of that sort of studies. We need more studies on this thrombin also. But the other one is almost proved. That's good. Any comments? You can close. Thank you. Thank you for that.
Ladies and gentlemen, we have reached the end of our second session and the final presentation in this hall. We appreciate your active participation and engagement throughout the day. As we conclude the scientific sessions, we invite you all to proceed to Hall 1 for a valedictory function, where we'll wrap up in ASL 2024. Please make your way to Hall 1, where we'll celebrate the success of this year's conference and bid farewell to new friends and colleagues. We look forward to seeing you there. Thank you, one and all, and this is your MC Divine sign off.